So here's the patient doctor.
Don't worry, son. I'll save your father.
What did doctor say here?
You, Obi, present this case.
Sorry, doctor. So, this patient is a 70-year-old truck driver who presents with symptoms of vision changes, nosebleeds, and also irregular morning headaches. So his blood pressure is 150/97.
And what does that mean?
That means he has mild hypertension. Okay, so he has been unresponsive to ACEIs and also calcium channel blockers. So that's all for the report, doctor.
So the treatment should be thiazides.
Thiazides?
Thiazides.
Thiazide.
We are moving on to the next class of diuretics, which is thiazides. Thiazides, they are commonly prescribed diuretics where they work in early part of the distal tubule. They increase the Na, the sodium chloride excretion by inhibiting the sodium chloride co-transporter. What they do is their mechanism is they decrease the sodium reabsorption where they inhibit the sodium chloride co-transporter, where this will in turn lower the blood pressure by increasing the sodium and also water increase excretion, where this will then decrease the extracellular volume, thus resulting in lower cardiac output and also renal blood flow. So with long-term use, the peripheral resistance decreases and thus diuresis is promoted. There are also direct vasodilation, which reduces the blood pressure and also the peripheral resistance. And lastly, they promote reabsorptions of calcium in the distal convoluted tubule. Thus, they will decrease the urine calcium. And they consist of drugs such as chlorothiazide, hydrochlorothiazide, and thiazide-like drugs such as chlorothalidone, metholazone, and also indapamide.
Here we have a case of hypertension in a 45-year-old male. His hypertension has been unresponsive to both angiotensin antagonist and calcium channel blockers. If we look into the NICE guidelines, this means that we have to move to step 3, which is to add thiazide or thiazide-like diuretics. Thiazides help to decrease blood pressure by two mechanisms. First, they decrease the blood volume by diuresis. This will decrease the venous return, decreasing the cardiac output, which leads to a decreased blood pressure. Next, they also cause arteriolar dilatation. This happens by relaxation of the arteriolar smooth muscle, decreasing the total peripheral resistance and decreasing the blood pressure.
Mr. Pharmacist, I needed to explain the side effects of thiazides.
There are side effects?
Don't worry, I will explain.
Hi everyone, my name is Mufliha Soleha, so I'm a pharmacist. So I will explain the side effect of the thiazide. One of it is hypokalemia. So as we all know, thiazide will inhibit the sodium chloride import in the renal tubules. So this will inhibit the sodium reabsorption. So when sodium reabsorption is decreased, it will decrease the intravascular volume. So this decrease in intravascular volume will activate the renin-angiotensin-aldosterone system. So this RAS system will activate the aldosterone secretion, and aldosterone will stimulate sodium reabsorption and increase the potassium secretion. So when potassium is being secreted out, so this will lead to hypokalemia. Another side effect of thiazide is hyponatremia. So as we all know, thiazide will cause hypovolemia. So this hypovolemia will stimulate the ADH secretion, and this ADH will diminish the kidney capability to dilute. So this will lead to thirsty. So the last side effect of thiazide is hyperglycemia. So this side effect usually occur in diabetic patient. So this thiazide will impair the insulin release and also decrease the tissue uptake of glucose, and this will lead to increased blood glucose level. Okay, so for the drug interaction, thiazide when combined with furosemide, which is a loop diuretics, it will cause synergistic effects, which is marked diuresis, hypovolemia, and cardiovascular collapse. Also, when thiazide combined with probenecid, this probenecid will inhibit the thiazide action. In addition to that, thiazide will also cause NSAIDs nephrotoxicity and lithium toxicity.
Sir, I think you need to lie down. You seem so tired.
Don't you think I want to do that? Do you know how many days it's been since I last left? It's been 2 days, man. Every time I've been lying down, I can't breathe, so I have to sit back out. And you want me to lie down? You want me to die? Don't worry, sir. We'll try to help.
So, medical student, have you examined this patient?
Okay, so this patient has a history of heart failure and he has a cough with frothy symptoms.
What's the diagnosis?
I read this yesterday.
How can you forget? So the patient might have a pulmonary edema. What do you think the drug should we administer to him?
What do you think, miss?
I think it should be furosemide.
Yeah, sure. Correct. We'll administer furosemide to him and we'll see how it goes.
Wait, furosemide. I know this drug.
Furosemide.
Great.
So how does this loop diuretic work? First, we need to know it acts on the loop of Henle, specifically in the ascending limb, where they are responsible for inhibiting sodium-potassium 2 chloride cotransporter. Out of all the diuretics, these agents produce the greatest diuretic effect, because as much as 25% of sodium gets reabsorbed in the ascending limb. This causes other parts of the nephron to be unable to compensate for the increased levels of tubular sodium. So let's take a closer look into the cells that line the thick ascending limb to see what exactly happens. So upon reaching the thick ascending limb, some of the filtered sodium, potassium and chloride gets reabsorbed by sodium potassium 2 chloride cotransporter. This, among other things, leads to the accumulation of potassium within the cell. However, potassium will also tend to leak out through the potassium channels back into the lumen. This contributes to a more positive charge. Now, this positivity gradient in the lumen produces an electrical driving force for paracellular reabsorption of the cations, such as magnesium and calcium. So when loop diuretic comes around and blocks sodium potassium 2 chloride cotransporter, we not only lose sodium and water, but also potassium, calcium and magnesium. Do keep in mind that potassium loss takes place mainly in the late distal tubule, where sodium-rich fluid enhances sodium-potassium exchange. Commonly used loop diuretics would be furosemide and tosemide, and it comes with a host of side effects besides just electrolyte imbalances. Loop diuretics can also induce rapid and excessive reduction in blood volume, which you guys may know it as acute hypovolemia. This can lead to hypotension shock and even cause cardiac arrhythmias. Also, undue side effect of loop diuretics is that since it inhibits sodium potassium 2 chloride cotransporter, this cotransporter also exists in the inner ear. This can lead to damage to the hearing, and this is referred to as ototoxicity. Furosemide in particular also tends to compete with the transport of uric acid at the same site, thus blocking its secretion, leading to hyperuricemia, which can worsen gout conditions. This is just a contraindication that I think you guys should know. And that is all I'll be highlighting on about loop diuretics.
In this case, the patient appears to present with pulmonary edema secondary to heart failure. Loop diuretics are the drug of choice for treatment of acute pulmonary edema. This is due to 3 reasons. First, similar to thiazides, they help to reduce the ECF volume by diuresis. In fact, they have the greatest diuretic effect of all the diuretics. Second, they are powerful venodilators. This means that they will reduce the preload, decrease the pressure in the right side of the heart, leading to reduced pressure inside the pulmonary circulation. Third, they have a rapid onset of action, meaning that these effects will allow for fluid to return to the blood vessels in no time, relieving the pulmonary edema and the suffering of the patient.
Great. Another drug. Is there any other side effects for this drug?
Well, there is, but don't worry. We'll go right back to Mufliha.
Okay, so for the side effect of furosemide is hyperuricemia, hyperkalemic metabolic alkalosis, and also the toxicity such as sulfonamide allergy rash. Gentamicin when combined with furosemide will cause ototoxicity. Also, furosemide when combined with lithium, it will reduce the lithium excretion, leading to lithium toxicity. Furosemide when combined with methotrexate will increase the risk of methotrexate toxicity.
Okay, never mind. So I'll check you. So how long have you been having this symptom?
For the past 1 week, doctor.
I see. This is your first time or is it recurring symptoms?
As far as I remember, this is my first time. I've never had anything before.
Can I take a look on your leg?
Sure thing.
Patient shows pitting edema.
I see. I know your problem. Never mind. Okay, so we have scanned your liver and it seems like you're having a liver cirrhosis that cause you swelling of your leg and also it will cause you hypokalemia. And don't worry, I already prescribed drugs to pharmacists. Later, pharmacists will explain to you what drugs that we've been given. Okay, that's all. I'll pass for pharmacists later. Okay, see you later.
Okay, Pradeep, for your condition, I will give spironolactone.
Spironolactone.
Now let's move on to potassium-sparing diuretics. So, potassium-sparing diuretics work primarily in the collecting tubule where they inhibit sodium reabsorption and also potassium excretion. Although these potassium-sparing agents are relatively weak diuretics, they are often used in combination with diuretics from the other classes in order to enhance their effects. Now, let's zoom in on the collecting tubule principal cell to see what exactly happens there. So, principal cell has separate channels for sodium and potassium, as well as sodium-potassium ATPase. On the basolateral side, under normal conditions, here sodium enters the cell through sodium channel and then it is transported by sodium-potassium ATPase into the bloodstream in exchange for potassium. Now, because the sodium entry predominates here, the lumen negative electrical potential is generated and chloride is driven into the bloodstream through paracellular pathway. This in turn drives potassium out of the cell through potassium channel. So, as a side note here, this illustration should also help you understand how loop diuretics and thiazides lead to potassium loss. So, increased sodium load caused by loops and thiazides enhance sodium reabsorption, which makes lumen more negative. This in turn generates driving force for increased potassium secretion and ultimately lower potassium levels in the bloodstream, hence hypokalemia. Now, going back to potassium-sparing diuretics agents within this class. can be separated into two groups based on their distinct mechanisms of action. So the first group works simply by blocking sodium channel, which results in decreased sodium-potassium exchange and thus retention of potassium drugs. Drugs that belong to this group include amiloride and also triamterene. Now, the second group on the other hand works by antagonizing aldosterone. Aldosterone is a hormone which gets into the cell, binds to the intracellular receptor, and stimulates transcription of genes encoding sodium channel and also sodium-potassium ATPase, thus increasing their expression. In other words, aldosterone leads to increased reabsorption of sodium and also water, and increased secretion of potassium. So, because aldosterone antagonists compete for binding to that intracellular receptor, that the result is reduced synthesis of proteins that activate sodium channels and decreased number of sodium-potassium ATPases, which ultimately leads to potassium retention. Drugs that belong to this group include spironolactone and eplerenone. Now, when it comes to side effect, as you may already guess, hyperkalemia is the biggest problem, especially when these diuretics are combined with other drugs that can also increase potassium levels. Lastly, due to its chemical structure that resembles our natural steroid hormones, spironolactone can stimulate receptors for testosterone and progesterone, leading to effects such as menstrual irregularities in females and gynecomastia in males.
This patient has hypokalemia together with generalized edema. This is evident by his feet not fitting into his shoes and pitting off his skin. Potassium-sparing diuretics are used in hypokalemia as they prevent potassium excretion. This will cause retention of potassium in his blood, allowing it to return to normal levels, thus correcting his hypokalemia. In this case, it also helps to treat his generalized edema. Spironolactone causes diuresis, which will reduce the ECF volume. Edema fluid will then diffuse from the interstitial space into the blood vessels, thus resulting in reduction of his edema.
Another drug. I wonder what is the side effect this time.
So now I'll be explaining on the adverse effect and also the drug interaction of spironolactone. So first off, for the unwanted effects, when using spironolactone, basically the patient can be having gastric upset. Secondly, if the patient happens to be a male patient, it will induce gynecomastia, and while if the patient is female, it can induce menstrual irregularities. Next, hyperkalemia, and we can also have nausea, lethargy, and also mental confusion. Lastly, the adverse effect I would like to highlight on is aldosteronism, which is also a feature of heart failure. Next, we'll be moving on to the drug interaction. There are two drug interactions that I would like to touch on. So first, when potassium sparing, for example spironolactone, is being used in combination with thiazides or any loop diuretics, basically these two drug combination will prevent hypokalemia. And secondly, let's say the potassium sparing diuretics is being used with angiotensin converting enzyme inhibitors. This will cause hyperkalemia. So that is all from me. Thank you.
Bro, you good? What
Mr. Irfan. As you can see here, this is your MRI image after we have examined you. And we can see there's some hemorrhage inside your brain, but it's not too severe. I'll try to describe you with mannitol first, and we'll see how it goes to reduce your pressure. And hopefully we don't need to do any operation after this one. Okay, where's my nurse? Nurse? Okay, nurse, please administer Mr. Irfan with mannitol intravenously to see how it goes to reduce his internal bleeding.
Alright, no problem, doctor.
Okay.
What's the name?
Mannitol.
Alright, mannitol.
Mannitol.
And lastly, we are moving to the last class of the diuretics, which is the osmotic diuretics, where these osmotic diuretics, they work by interfering directly with the osmosis. As we all learned before, we all know that the water tends to move from the diluted side to a much higher concentration side. So these osmotic agents, they filtered from the glomerulus where they undergo the limited reabsorption. This is mainly due to their large molecular size. So this will in turn lead the increase in osmolarity of the tubular fluid, and thus leading to decrease in the water reabsorption. So there will be more water excretion. What they basically do, the example of the drugs include mannitol and urea, where mannitol, they actually elevate the blood plasma osmolarity. So as mentioned earlier, there will be increased flow of water from tissues, the interstitial fluid and plasma. So they promote urinary excretions of toxic materials, and they protect against nephrotoxicity by preventing the concentration of toxic substances in the tubular fluid.
A hemorrhage inside the body may accumulate within a tissue to form a hematoma, in this case in the patient's cranium or head. Since the skull is not distensible, this means that hematoma will take up space inside the head, building intracranial pressure and causing compression on the patient's brain. The doctor prescribed mannitol, an osmotic diuretic which pulls water from the cerebral tissues into the blood vessels. This will decrease the cerebral edema that may be present, relieving the intracranial pressure and the patient's symptoms. It also promotes diuresis. However, this is less significant compared to its effect on the cerebral tissues.
Okay, so for the side effect of mannitol, firstly is hyponatremia. This is because the water will move from intracellular to extracellular, leading to ECF expansion. And secondly is headache, nausea and vomiting due to hyponatremia, and also will cause dehydration due to water loss.
How can I help you? Doctor, I think I'm having a blood and arrow vision and very bad pain in the back of my eyes and also eyeballs.
It's
Very painful. I don't know what to do.
Is that all your symptoms?
Yeah, that's all.
I'll just run some tests.
I think you may have glaucoma. I'll write your prescription and ask the pharmacist help you out. Yeah. You're welcome.
Your name is Irfan Jahmi, right?
Yes.
Okay, so here is your medication. Its name is acetazolamide. Okay, I'm just giving.
Acetazolamide.
Now let's see how this carbonic anhydrase inhibitor works. The carbonic anhydrase induces a diuretic effect mainly by reducing the reabsorption of bicarbonate in the proximal convoluted tubule. Now let's take a closer look to the epithelial cell of the proximal convoluted tubule to see how they do so by understanding what occurs in the PCT. So here on the diagram on the left of the epithelial cell, we have the lumen where the urine is being formed, and to the right we have the interstitium which contains our vasculature. so our blood vessels. Now here the bicarbonate reabsorption is initiated by a membrane protein, namely called sodium hydrogen ion exchanger. This sodium proton exchanger allows sodium to enter the cell in exchange for hydrogen ion. Next, the reabsorbed sodium is pumped by the sodium-potassium ATPase out of the cell, where the secreted hydrogen ion combines with the luminal bicarbonate ion to form carbonic acid. Then, carbonic acid is then rapidly dehydrated to carbon dioxide and water by the enzyme carbonic anhydrase. CO2 enters the epithelial cell by simple diffusion and gets rehydrated back to carbonic acid by intracellular carbonic anhydrase. Finally, intracellular carbonic acid dissociates to form hydrogen ion, which can be transported by sodium hydrogen exchanger to the lumen, and the bicarbonate ion, which is transported out of the cell. Now when carbonic anhydrase inhibitor comes around, it inhibits carbonic anhydrase enzyme, and as a result, bicarbonate gets retained in the lumen. Since bicarbonate reabsorption utilizes the sodium hydrogen exchanger, inhibition of carbonic anhydrase leads to significant reduction in proximal tubule sodium reabsorption, which results in mild diuresis. The reason why it's mild is because that the majority of the sodium does not get reabsorbed in the proximal tubule, and is then reabsorbed later in the distal parts. But since the reabsorption occurs later, it also leads to an increase in potassium secretion, which is one of the side effects associated with this class. Additionally, because bicarbonate is a major component of the acid-base buffering system in the circulation, its wasting leads to an increase in plasma acidity known as metabolic acidosis. The most commonly used drug is acetazolamide, where it induces a weak diuretic effect.
This is a case of open-angle glaucoma, a condition where the trabecular meshwork fails to drain aqueous humor properly. This causes excessive accumulation of aqueous humor inside the eyes, leading to increased intraocular pressure, hence the headaches. Acetazolamide is used to treat glaucoma by inhibiting carbonic anhydrase, an enzyme which is important in order for aqueous humor to be secreted. Therefore, the volume of aqueous humor inside the eyes will be reduced, relieving the intraocular pressure and relieving the symptoms.
Hello, so I will be explaining on the side effects and also the drug interaction of using acetazolamide. So basically there are a few things that I would like to highlight on when you start to take acetazolamide. So one of the things is you will be having metabolic acidosis, potassium depletion, which is also known as hypokalemia, and you should know that you will be facing drowsiness and also paraesthesia. That is for the side effects. While for the drug interaction, there are two things. One is that it cannot be used together with salicylates because it will cause accumulation and further toxicity. And this toxicity will focus more on the CNS, where it will cause severe metabolic acidosis. And the second thing is when you use it with sodium bicarbonate, what would happen is that it will basically increase the risk of the formation of kidney stones. So those are the two drug interactions that I would like to highlight on. Thank you.
Last night I lost all my patience. You were fucked up, I was wasted. Midsummer madness, I can't take it no more.